I'm just live streaming.
Yeah.
It is live streaming now. No, no, no. It is just live streaming. It will come there in Zoom. It will take you 1 minute.
Bangalore is still raining, ma'am?
Today it's not there, sir. Today it's quite okay. At least now it is sunny outside.
Okay.
Maybe evening we won't know. We had change of CM in your absence, sir. We changed our chief minister.
I know, Dr. Mr. Mumbai.
Two devices I have to stop this one. Okay.
Stop this live stream. Please ಮಾಡಬಾರ್ದು. Stop it. Please stop it. Stop this live stream. Please ಮಾಡಬಾರ್ದು. Stop it. Stop it.
Do there only.
I'll do it.
Okay, you do. So we are live now, both in Zoom as well as it's being streamed in YouTube.
Yeah.
Attendees will be able to join now.
We'll wait for 3 minutes exactly, and 4 o'clock sharp we will start.
Yes, sir.
Okay, I'll start, ma'am.
Okay.
Right, we'll start now. Yeah. Good evening, everyone. On behalf of Micro Labs and Micro Knowledge Academy, it's a great pleasure to invite all of you for this World Hepatitis Day webinar. Acute viral hepatitis, it is just not a game. The title itself indicates that there is going to be something interesting and exciting uh, in the annual. And welcome you all for this exciting event. I take this opportunity to welcome Dr. Manjula Suresh, our Senior Vice President of Medical Affairs and our mentor, academic mentor, to take this forward and introduce the speaker, who is none other than Dr. N. Arun, Senior Consultant Gastroenterologist of Apollo Hospital, Chennai. And again, before winding up, I would like to once again welcome all of you for this event. Over to Dr. Manjula Suresh.
Thank you very much, sir, for your kind words. Good evening, everyone. I once again welcome you all to this evening's webinar titled Acute Viral Hepatitis, a Jest, Not a Game. And I take this opportunity to welcome our eminent speaker, Dr. N. Arun, as well. All of you know today is World Hepatitis Day. And you're aware of World Hepatitis Day, which brings world together under a single theme to raise the awareness about global burden of viral hepatitis and also to influence the real change. So this time, the theme has been 2021 theme has been Hep Can't Wait. And we all know that viral hepatitis is a significant healthcare burden across the globe. And numerous viruses are known to cause liver inflammation, which includes but not limited to Epstein-Barr virus, herpes simplex virus, and cytomegalovirus. However, the hepatotropic viruses A to U are the most common culprits. And most of the hepatotropic viruses are acute and self-limiting, although forms of Hep B, C, and E have the potential to become chronic, and there are occasions it can lead to hepatocellular carcinoma. So various genotypes of the viruses exist, with some being more prominent in specific geographical locations than others. And also, why this day is being celebrated, why this theme, with a person dying every 30 seconds from hepatitis related illness. Even in the current COVID-19 crisis, we can't wait to act on viral hepatitis. To keep in this theme, we have organized this webinar. As I mentioned, there is a lot of genotypic variants and there is a lot of complication. Hepatitis illness can't wait. So hence we have named it also hepatitis A. It's not easy to treat a viral hepatitis. It's not just a simple game to teach. There's a lot of things you need to take care before you administer the medication, how to manage a patient, how differently, and what are the different genotypes. So a lot of updates have happened, a lot of things have happened. So we have very fortunate to have very eminent speaker with us, very well known to all of you. As I always say, sir does not require any introduction, but as a formality, I'll be doing the honor of introducing sir to all of you. Dr. Arun is our distinguished speaker today. He's Assistant Professor of Gastroenterology at the Department of Digestive Health and Diseases, Chennai. He's also a Senior Consultant at Apollo Main Hospital, Chennai. He's also Director at Chandra Gastro Liver Clinic and Endoscopic Center, Chennai. His special areas of interest include post-liver transplant immunosuppressive guidelines, plasmapheresis in ACLF. He has several association membership. To name a few, he is a life member of ISG, INASL, SCEI, as well as Indian Association of Physician, IAP, Indian Academic of Pediatrics. Sorry. So he has a very rich experience of handling these cases, and he is a very ardent speaker. He has several publications to his credit, and he is a very well-known speaker both in national as well as international forum. So, Dr. Arun sir, it's welcome to you. It's our pleasure to have you. May I now request you to kindly take over and make your deliberation. Over to you, sir. Thank you very much.
Thank you, Dr. Manjula, who gave me a reasonable brief introduction. It's really a great pleasure for me to meet you all once again this wonderful evening. And I'll be sharing my screen right now. I think you can able to see my slides, no? My slides are well visible.
Yes, sir. Visible.
Yes, sir. Yes, sir.
Very clear.
So it's really a great pleasure. Good evening, to one and all. I would like to thank Microlabs, and I would like to thank all the delegates who are being here to participate in this most common area of discussion. What we are going to do right now for the next 45 minutes to 1 hour about the most common clinical scenario for a physician or a surgeon or a gastroenterologist, for whomever is going to encounter, even for the over-the-counter prescribers. All those persons will be encountering these kind of scenarios frequently in the practice. Why I would like to I have chosen this topic mainly to highlight what you're supposed to know, how you're going to tackle once the patient is going to land up with this acute viral hepatitis. See, if you're going to look into this, today it's World Hepatitis Day, July 28th. It's going on 2021. The theme is nothing but yep can't wait. If you're going to look into this, so I have just chosen an option. It's just not a game. How are you going to play with this scenario? If you're going to take on this scenario, viral hepatitis, it's basically anything which is going to happen in your liver, which is going to establish a chronic and primary inflammatory process by a group of heterogenic group of viruses. What are the various viruses going to tackle? Based upon that, the inflammatory cascade is going to set in your liver, which leads to viral hepatitis. So there are multiple terminology right from your MBBS knowledge, right from your MD, and right from your DM cadres. You have been looking into this. So it's nothing but acute means it should be less than 6 months. So symptoms will be of less than 6 months of duration. Hepatic failure in acute scenario, you should always remember if the patient is going for encephalopathy or if the patient is going for coagulopathy with loss of function in the background of worsening of jaundice, and if the patient deserves intensive care admission for which you needed a chronic management therapy, that's nothing but acute hepatic failure. Chronic hepatitis is a terminology. Once you're going to inflammatory cascade, if it is going to progress for a period of more than 6 months of duration. Cirrhosis, if you're going to look, it's nothing but the established inflammatory phase. If it is going to get fibrous followed by the shrunken out state of liver, it's going to get formed, and followed by you are going to lose your liver functions, basic functions, which will predispose to cirrhosis. And fulminant hepatitis, that what have been discussed, like hepatic failure, every impairment, the severe impairment of your hepatic function, and followed by there is evidence of necrosis of your hepatocyte in the absence of any pre-existing inflammation, pre-existing liver disease. There is high possibility for this fulminant hepatic failure to happen in the background of viral hepatitis. That's why I am being here to take on this scenario to discuss with you all in this wonderful evening. So as we all know, hepatitis virus is one very simple area to discuss, but very complex phenomena to understand and very complex area to tackle in your daily practice. So if you're looking into this basic thing right from your basic knowledge from A, B, C, D, and E type of virus, the basic discovery from 1965 to 1980 for B to E, which has been progress, we need to look into that. And next to that, this is nothing but the Nobel laureates right now being, actually they have been discovered this hepatitis C virus even by 1980 to 1982 period, followed by they have been awarded this Nobel Prize by 2020. If you're going to look into these three great persons who are being main area to discuss, take on the area of hepatitis C, for them to have been awarded Nobel Prize right now. So if you're going to look into this viral hepatitis, is mainly there is multiple modality for this virus to get enter into your tract. It could be because of your fecal-oral route. It could be because of your multiple hematogenous spread. There are multiple modality for you to transfer this virus. But hepatitis virus, if it is because of infectious event, it could be because of A or E, because of fecal-oral route. If it is not going to be a serum-related hepatitis, if it is going to be a serum-related, there is high possibility for your hepatitis B to supervene. There is high possibility for your hepatitis C to supervene. There is high possibility in the background of hepatitis B. Always you need to think in the worsening of scenario, hepatitis D virus should not be forgotten if the patient is having coexistent hepatitis B virus. So there is evidence of enterically transmitted, there is evidence of systemically transmitted, and there are so many aspects you need to look into the scenario for it yourself. How are you going to classify this based upon your epitophic or non-epitophic and based upon your DNA as well as your RNA status? As we all know, the DNA is common by hepatitis B, and RNA is other than all the viruses is going to take on to that. And non-epitophic viruses like dengue, herpes simplex, or Epstein-Barr, or so many other viruses to look into that. That I'll be taking over in my upcoming slide of presentation. So how the viruses is going to get transmitted, that's what been discussed, is parenteral, various modality. If you're going to use syringe, if you're going to go for frequent outside shaving, razor using, and if you're going to tattoo frequently, so always you need to take care of the basic measures, blood and blood product sharing, syringe exposure, all those things to be controlled properly. And even then, if your blood product is being negative for your hepatitis B or C, it's more important to look for the DNA status, because there is high possibility for you for even the microns of viruses to escape, and there is high possibility for you to land up with this kind of dangerous hepatic pathology, which may predispose to chronicity. Why I would like to implicate in this area, once a patient is going for B and C, there is high possibility for this kind of patients to go for chronic viruses, chronic hepatitis, followed by you are going to land up with cirrhotic background, and there is high possibility for you to land up with the dreadful complications, nothing but hepatocellular cancer. So always you need to look into the format, whether this patient is being presenting or not, based upon your clinical presentation, based upon your clinical scenario, by history and assessment, by the various area, endemic exposure, whether the hyperendemic or low endemic, all those things to analyze properly if you want to discuss about this hepatitis pathology in a normal manner. And apart from that, the fecal oral, nothing but if you're going to use, unhygienic source of modality, flies, food, fingers, all those things can harbor this hepatitis A as well as hepatitis E. And transmission is mainly by perinatal. If you're going to look for perinatal modality, almost 60 to 70% will be hepatitis B viruses, and C can be doing that. And apart from the sexual modality, also by B and C can be happening. An outcome, if you're going to look into that, the base of onset and duration, either it was going because of acute hepatitis or chronic, always the chronicity, you need to look for B, C, and D. But our area today to discuss with you all what you're going to do if the patient is going to land up with acute hepatitis, how are you going to manage, who are the patient deserve hospitalization, how are you going to approach this kind of patient, whether it is because of B, what are the basic investigations, what are the superadded investigations, that all the things we are here to discuss right now with you all. Apart from that, acute hepatitis, as I discussed, A, B, C, and E even can present. As well know that B and C, there is high possibility for chronicity, and B and C can also land up with acute modality of presentation. So this is a basic outline which is being given right from your basic textbooks. If you're going to look into the structure, so hepatitis A is predominantly a single-stranded fecal-oral modality. Main thing we are supposed to remember is it has a short incubation period of around 10 to 50 days, and B will be having a short, incubation period of prolonged duration of almost around 50 to 180 days, and viral hepatitis C will be around 40 to 120 days, and D will be around 2 to 12 weeks, and E will be around 2 to 9 weeks. So the single-stranded RNA for most of the things except for B virus, which will be having double-stranded, and parent and fecal-oral route for A and E, as well as your parental sexual will be there for B, C, as well as your D viruses, which is supposed to be looked into that when you're going to. And most of the time, the carrier state will be a very common phenomena in hepatitis B virus. Also, it can happen in hepatitis C, but most of the time, hepatitis A will not be having any carrier state. You need to look into that. And this is how the virus family, like basic questions, if you're going to look into that, the Picano, Hepadno, Flavi, Delta, and Calci, based upon your various viruses are being classified. This is the outline of your structure, icosahedral shape, followed by your Dane particle of your hepatitis B viruses and hepatitis C virus, D, all those things, the basic virology structure, this is all being given. And when I'll be discussing individually, I'll be showing all those things to you all. And the basic thing, if you're going to remember a clinical scenario, for example, daily, practice, if you are getting a case who, for example, a 25-year-old middle-aged man who are going to present to us with history of yellowish discoloration of eyes and urine, followed by, if the patient is going to have a preceding prodromal symptoms like fever, myalgia, arthralgia, sometimes any rashes, could be a predisposing presentation prior to the onset of jaundice, there might be evidence for this kind of patient to land up with viral hepatitis. Once a patient is going to land up with this kind of viral hepatitis, how are you going to approach, how are you going to manage, who deserves management, how are you going to symptomatically tackle and recognize the complications earlier, whether the patient is going for failure or not, whether the patient is going for coagulopathy, whether the patient is going for hepatic encephalopathy, whether the patient is developing cerebral edema, whether there is any possibility for this kind of patients to develop multi-organ dysfunction, whether there is any possibility for this kind of patients to land up with acute respiratory distress syndrome or any septic focus or any other extra GA manifestation. That all we are going to discuss. That's how we need to approach each and every patient when you're going to tackle a patient with acute viral hepatitis. If the patient liver enzymes is in the ISO, the AST-ALT ratio, if it is going to be high, and alkaline phosphatase, sometimes in the background of cholestatic jaundice, which is going to more commonly happen in the background of acute hepatitis A, there is high possibility for you that cholestasis, for which may be landing up for almost a period of around 10 weeks. So you need to look for that kind of patients, whether the patient is having only hepatocellular pathology, or whether the patient is having cholestatic pathology, or whether the patient is having combined pathology. All these pointers to be analyzed properly if you want to manage a patient with viral hepatitis in the spectrum of gastroenterology and hepatology. It's most common to discuss right now with you all. So other infections like CMV, EBV will be having a coexisting other presentation. There might be evidence of immunosuppressive state. There might be evidence of a coexisting HIV. Other infections can supervene, but always there might be evidence of any granulomatous hepatitis can supervene in this kind of presentation. But why I would like to point here, you need to remember acute viral hepatitis could be any modality, but the most important thing we are supposed to look into that. You should not miss out any common diagnosis in managing a patient with acute viral hepatitis. So about 15 to 20% of B virus can take up a form of acute hepatitis B, and HDV also can have a super infection or co-infection along with hepatitis B, and HCV usually will be a rare cause of acute hepatitis, but some scenarios still existing, but majority will be self-limiting of acute viral, and fulminant hepatic failure usually will be less than 1%. That you're supposed to remember that. And once a patient is going to land up with fulminant hepatic failure, we need to look for the entire spectrum, whether it is only because of viral or whether it is going to be because of other super existing, whether it is because of any metabolic events, or whether there's any autoimmune focus, or whether the patient is going to have any drug-induced focus. All those things to be looked into an account. Don't think that once a patient is having A positivity, the patient is having problems is only because of A. Once a patient is going to land up with B or C, doesn't mean the patient is having problem only because of that. So assessing the clinical parameter, assessing the clinical pointers, all those things from head to foot examination, that has to be done properly if you want to diagnose in an exact manner for this evidence of viral hepatitis to point out. So basic symptoms like anorexia, nausea, vomiting will be a characteristic presentation, and there might be having high colored urine, and jaundice will be a characteristic one, and liver enzymes definitely it's going to be high, and ALT sometimes will be going to be, in case of acute events, will be more than 10 times of your upper limit of normal. And always you need to rule out the toxins. Mainly it could be because of any drugs, or it could be because of alcohol, or any ischemic focus, or any of the venomic focus, or any of the coexisting chronic liver disease, or any of the vascular events, or it could be a extra hepatic pathology, meaning biliary obstruction or other things can supervene. Always you need to rule out all the possible pointers if you want to diagnose this hepatitis virus in a properly. And next to that, rule out all the common investigations. Don't think that for all the patients no need to do complete virology panel, because we are living in a very poor country in which most of the patients could not able to afford. So you need to decide what is the primary investigations you need to do. So I have seen some many centers who have been doing, once a patient is going to land up with low grade fever and mild jaundice, they'll be doing a complete virology panel. That's not absolutely indicated. First, what I would like to point you all, because if you're going to do complete virology indicators, some pointers may turn to be positive, which is absolutely not needed for this kind of cases when you're going to present. That's why, what is the aim, what is the area, what is the target you are analyzing? That's how you need to influence your case, and followed by you can step up your investigations in case if you couldn't able to land up your diagnosis at the earlier presentation. So chose the basic investigation, do in a proper manner to analyze the event, what is there to progress. And rule out once a patient doesn't show evidence, and we can look for other and non-epidotrophic viruses like what I've been discussed with you all, and sometimes autoimmune markers like ANA and ASMA to be looked into that, and rarely metabolic liver focus like Wilson's and other things based upon your age criteria, based upon your hepatic involvement, based upon your neurological status, all those punches to be looked into an account if you're going to manage a patient with high jaundice in the background of low-grade fever with worsening of symptoms with evidence of prodromes. So hepatitis, if you're going to look, the common virus, nothing but hepatitis A, which is the main area for me to discuss because of acute viral. Most of the time in Indian scenario, there is high possibility right from pediatric age group to adult population to land up with hepatitis A virus. It's common infectious hepatitis. It's epidemic jaundice. It's mainly originally called as enterovirus 72. Most of the time, the disease will be a benign course. Sometimes the disease may go for a fulminant hepatic failure. As I discussed with you all prior, it's mainly by a fecal-oral route of transmission, and India is always a hyperendemicity, shows always hyperendemicity for this hepatitis A, and mostly by fecal-oral because of poor hygienic practices, poor water environment, poor sanitation practices, all those things. This is how the widespread among the global population of this hepatitis geographic events which is going to happen, and how the epidemiological determinants is going to based upon the agent, based upon the host factor, based upon your environment, right from the basic knowledge of your community medicine. How are you going to establish diagnosis, the agent, host, and environment? This triangular approach is needed if you want to tackle this virus in a common, proper manner. And see, this is how the agent of hepatitis A, spicanoviridae family, as I discussed with you, the viral proteins, nothing but a single-stranded RNA virus, which exhibit a predominantly icosahedral shape. It may be having one serotype, but there are more than 3 genotypes are being there, which has been proven in that. These are all the basic things. If you're going to look, it may survive in your feces for more than a period of almost 4 weeks. So you should be very careful. It may share, there are various modality for you to get transmitted, and even it can withstand your eating capacity up to 60 degrees Celsius for a period of almost around 1 year. And I mean 1 hour, you need to look into that. And the common reservoir will be a human cases will be, and the infectivity period will be it's greater from 2 weeks before to 1 week after the onset of jaundice, and infection is mainly by your fecal matter, and viral excretion can go up to 2 weeks before, and as I discussed with you, it can go up to 2 weeks after also. So you should be very cautious during this period. And sex wise equals, both ages will be affected, and immunity usually probably lost for life, and age factor, pediatric age group is more common than your adult population, and environmental factors, you need to look into that. And main route of transmission, that what I've been discussed is fecal oral, but there are some patients case reports even by intrafamilial sexual contact with an infected person, rarely by your parental spread. There are some case reports rarely by ingestion of your contaminated food, and these are all the sources for you to acquire the infection. And the risky persons are immunocompromised, you are going to travel to endemic areas, who are going to have a frequent sexual contact with the infected persons, and the men having sex with men, homosexual partners, and any evidence of any drug abusers. There is high possibility for this kind of patients to progress to high evidence of hepatitis A virus, and the usual period of incubation will be less than 50 days. And the various modality for you to detect this virus, it can excrete in various forms. You can detect either in stool or blood or bile or urine or in nasopharyngeal secretions, or even in your vaginal fluid, you can able to identify, but mainly in your stool. If you're going to look into that, it will be detectable in up to 45 and 11% of fecal specimens. Usually you need to collect during the first and second week of illness, whereas HIV RNA, you can detect even up to 4 to 5 months of onset. So this is how the pathogenesis is going to establish. You're going to ingest a virus, the replication is going to start from your oropharynx to your GI tract, and you're going to transport. This is a major site of replication in your liver, and it may be shedding in your bile and feces. A brief viremia and cellular immune response is going to progress. That is how the established pathophysiology of your hepatitis A. And this is a replication which is going to happen. If you're going to look into this, the hepatitis A virus is the predominant receptor site it is going to enter into hepatocyte. Once it's going to enter, there is high possibility for this to go for a virus uncoating event and the multiple RNA copy which is going to get released, followed by there might be evidence of your virals to get assembly, and there might be evidence of this get to package into vesicles, followed by your viral assembly, followed by your capsid formation, and once it's going to get released into your bile canaliculates, followed by it may be releasing into your feces. That's how the replication of your hepatitis A virus can progress. And common basic fundamental, any viral hepatitis can go for a prodromic phase or ectric phase or recovery phase if you're going to look into the clinical picture. So the prodrome is nothing but if you're going to have a short-lasting symptom, a low-grade fever, a myalgia, arthralgia, rash, these are all the evidence of any, these are all the presentation for your prodrome. Once the patient is going to land up with jaundice, followed by your liver enzymes is going to go high, there might be evidence of your fever and other will be coming down, and slowly over a period of 2 to 3 days, you can see the patient is going to have a recovery. So main thing, why I would like to point this slide, this has been taken from the recent paper. The asymptomatic phase will be common in case of without jaundice. Sometimes the patient will be symptomatic with jaundice. Usually it will be self-limiting over a period of 8 weeks. And always you should remember a cholestatic jaundice. There is high possibility for this cholestatic jaundice to last for a period of almost around 10 weeks. And relapsing hepatitis, by hepatitis A, what do you mean by this relapsing event? If it is going to be multiple bouts, more than 2 bouts, if it is going to happen in a short span of time, that shows evidence of relapsing hepatitis, and around less than 1% of the population can develop fulminant hepatic failure. So always you should be very cautious to look into that if you want to manage a patient. So all the various patterns can happen in the pathophysiology as well as in the clinical domain if you're going to look into this acute viral hepatitis because of hepatitis A. The common symptoms, very common phenomena, nothing much to discuss. Look for the clinical pointer, look for evidence of septicemia, see the patient is deeply jaundiced or not, see, deserve the patient, whether the patient needs hospitalization, look for any other coexisting, do head-to-foot examination, never miss pickle, nothing but parano, ictros, clubbing, your significant lymphadenopathy is there or not. Based upon your clinical examination pointers, look for evidence of hepatic encephalopathy, like looking into flapping tremors, and look for evidence of any covert features of hepatic encephalopathy by doing the basic assessment, and see whether the patient is going to have any rashes in the form of ecchymosis, petechiae, purpura. It could be because of your vascular leak, which is going to happen, or it could be because of your drop in platelets, or it could be because of any other non-hepatotrophic viruses like your dengue or other scenarios to supervene. Always you need to analyze. See, analyzing is most important in the field of medicine. When you're going to analyze your patient properly, I'm very sure you're never going to mess up your diagnosis and you're never going to mess up with the patient. So how are you going to approach is the most important phenomena. The common thing, the basic investigation, do IgM anti-HIV. If it is going to be positive, that shows evidence of HIV, and look for negative phase. If it is going to be negative, either the patient is going to be vaccinated or already been immune to that. So diagnosis mainly by viral isolation. You can detect it through any other sources. Nothing much, your basic blood investigations. You can do a PCR if it is needed, but not absolutely indicated in your clinical practice. So investigation-wise, the bilirubin, urobilinogen can be found in your urine and other samples, but usually urobilinogen will be found late in pre-ectric phase. It disappears at the height of jaundice. It represents, its reappearance indicates the period of recovery. So what is there about the liver biochemistry? The ALP, liver enzyme elevation, can be the AST, will be significantly elevated. Sometimes in the background of cholestatic hepatitis, there might be evidence of ALP elevation. So usually it may rise up to around 500, and always you need to see whether the patient is going to drop onto this level consecutively by your management cascade, what you're going to initiate with that. And hematological manifestation that what I mean discuss, leukopenic picture is a characteristic one. Neutropenia can be there in your pre-icteric phase. Aplastic anemia may be reported, but even then it's a rare event. There are some papers are being there to report that. And apart from that, your virology, I mean, your vascular markers can be prolonged. The PTINR can be increased, and INR if it is going to be more than 1.5, which means you're going to for evidence of fulminant hepatic failure. You need to look for all the pointers to analyze this event properly. And IgG anti-HIV, which means if it is going to be positive, that shows evidence of vaccinated or previously infected. So HIV RNA can be detected, but not much of use nowadays, but mainly IgM anti-HIV is mainly indicated if you want to diagnose a patient with acute hepatitis A infection. So in areas of high prevalence, most children have antibodies by the age of 3 years following a asymptomatic infection. So you need to take all these pictures properly. And this is how the initial period will be having a IgM anti-HIV, which will be sustained and will be increasing, followed by IgG will be taking your course in the later phase. And once a patient gets improved, the symptomatic recovery, it's going to be persisting for a longer duration of time. So the treatment, nothing but your supportive care. And sometimes once a patient is going to have a fatal course, there might be evidence of intensive care protocol that I'll be discussing with you all briefly. And mainly based upon your bed rest and diet modification therapy, and followed by high low fat, high carbohydrate diet. That's the most important thing. Steroids, no significant potential benefit. It's being there to prove in case of acute viral. And when high protein diet, when appetite once started up, we can go for that. But usually any patient in the background of jaundice, alcohol is strictly denied, preferably for a period of next 6 months to 1 year. And there are some brief role of silimarin. I want to like to point in this slide, because silimarin can be, it's nothing but a milk thistle extracted derivative. It's nothing from a silibinin extract. If you're going to look into that, the silimarin will be having anti-inflammatory, anti-fibrotic, and multiple beneficial role, and anti-apoptotic effects can be proven. So it is going to act in your inflammatory cascade. It is going to act in your apoptotic pathway. It is going to act in your metabolic effects. It is going to act in your oxidative stress. There is high possibility for that to bring down the fibrosis, and even in your choleratic activity, in which case, if you're going to land up with high evidence of pruritus. See, I'll be telling you some common scenarios. Once a patient in the background of acute hepatitis A virus, there is high possibility for that kind of patients to go for cholestatic pathology, and most of the time the patient will be having a disturbing pruritus. Once a patient is going to land up with this kind of disturbing pruritus, you should be very cautious. And whatever the medications we are going to use for that, either you're going to support the patient with UDCA or silimarin or rifampin or whatever the modalities we are going to use, you need to be cautious in subjecting the patient, or even if you're going to use your cholestyramine for that kind of scenario. So be cautious when you're going to subject. Once a patient is not going to improve, the entire pruritic pathology is very complex. That itself is indicating the patient is going for fulminant hepatitis. That itself is a persistent, the patient is going to deserve a liver transplant in the background of cholestatic hepatitis. So I would like to point out there might be having a multiple beneficial effects of this silimarin, which inhibits your predominant transcription factor like N of kappa B, which is the predominant pathway is going to involve in hepatitis A, hepatitis E, as well as your hepatitis C viruses. Apart from that, and it inhibits your TNF alpha, so it's going to downregulate your apoptosis, and it's activate your estrogen receptors, which are another, and anti-androgenic in prostate cancer. So there are so many pathways for this to consider in the management of your acute viral hepatitis. You can try, but we need more papers to validate this, but this can be added on to your armamentarium if you want to manage a patient with acute viral hepatitis. And next to that, the various complications, nothing but as I discussed, either hepatic focus or non-hepatic focus, a fulminant hepatitis, you should not miss out a cholestatic picture, extra GI focus like your nephrotic or autoimmune pathology or relapsing events or rare extrahepatic manifestations like There is a huge list of rare extrahepatic manifestation like your arthralgia, leukocytoclastic vasculitis, glomerulonephritis, and cryoglobulinemia. So there are huge list for cryoglobulinemia. If you're going to consider, it can happen in A, it can happen in B, but most common scenario, you need to look for your hepatitis C virus and your aplastic anemia and thrombocytopenia and superweight. So how to prevent this hepatitis A viral infection? We need to maintain a safe hygienic practice. That's how the proper drinking water, a safe hygienic practice, a proper sewage disposal, and screen yourself. And prophylaxis is one very common area, because right from age 1, we can give hepatitis A vaccine. Nowadays being recommended even by Indian Academy of Pediatrics. You need to give that vaccination, and sometimes you may need to go for a booster dose of vaccination by around 6 months, 1.6 months of age, 1.6 years of age. And that's how we need to tackle. And immunoglobulin you can try based upon, you can go for a pre-exposure prophylaxis, and you can go for a post-exposure prophylaxis once you're going to expose to a patient who have been previously infected with hepatitis A, and you are going to have a chronically immunocompromised state. In that case, you can go for a post-exposure, or if you're going for a high prevalent areas, high endemic zone, you can go for a pre-exposure prophylaxis for your immunoglobulin. And even for pediatric age group of less than 1 year, you can go for immunoglobulin, but not hepatitis A viral vaccination. The vaccination protocol is huge, and there are varied forms of vaccination. So you can go for basic vaccination being accepted now mainly up to 18 months of age, start from 1 year up to 18 months. We can consider there are various formulations. By that, we can use the Twindex is nothing but a combination of B as well as A. We can consider all those things if you're going to manage a patient with hepatitis A virus, your vaccination protocols. So this is what the post-exposure prophylaxis. There are so many other pointers, a daycare center, a common source exposed area, if you are a school-going person, say hospital workers, or a close personal contacts with your index primary case, all those things are having high risk of transmitting hepatitis A. They can go for post-exposure prophylaxis. So mainly the recommendation will be a pre-exposure will be any patient who's going to avoid transplant in the background of chronic liver disease, or the patient who already undergone the transplant. If the patient is going to have a coexisting immunocompromise like HIV, or if the patient is going to have hepatitis B virus, there is high possibility for you to land up with HIV also. So you need to take all the vaccination. Most of the time, the outcome will be very good in the background of hepatitis A, and fulminant hepatitis will be very less for your less than 1%. That's what the main area for me to discuss about this hepatitis A. And next to that, hepatitis Z, if you're going to look into the target, it's nothing but a non-A, non-B virus or epidemic NA and B. It's mainly by the family of Calciviridae. One thing about hepatitis Z virus, what I would like to highlight, any pregnant woman, we should be very, very cautious, because once a patient is going to land up with jaundice, once you're going to give a call to the gastroenterologist, there is high possibility for this kind of patient to land up with hepatitis E virus. And once the patient is in pregnant phase, in the second and third trimester, there is high possibility for you to land up with worsening events in the form of fulminant hepatic failure. The viral particles may shed in stool and accusated symmetry 27 to 34 nanometer. These are all the theoretical purpose, but what is supposed to remember, hepatitis E virus is having a complex structure with multiple proteins, as well as your reverse transcriptase, which is going to involve, followed by it is having a lipid bilayer envelope, and there will be a RNA, structural RNA, which is going to involve in the formation of your hepatitis E viral structure. There are many genotypes, mostly 4 genotypes are there in India, but the prevalent will be 1, and usually 1 and 2 will be hyperendemicity, and 3 and 4 will be hypoendemicity areas, will be predisposing in that. If you're going to look into the papers, the most common modality will be fecal-oral, but rarely parental modality of transmission also being reported with this hepatitis E virus. So how are you going to differentiate this hepatitis A virus from your hepatitis E virus? If you're going to look into that, A will be more common in pediatric age group, but HEV can happen even in the younger population or slightly in a young adolescent or adult population. And once a patient is going for HEV, the fulminant hepatitis, as I discussed in pregnant women, it's mainly more common because of your HEV. And secondary attack rates is always very, very low as against your hepatitis A, which we having very high levels, will be around 10 to 20% of secondary attack rates will be there. But both of them is going to get transmitted by a fecal-oral route. So you need to look for this global predominance where the virus is going to look into that. And Next to that, this common differentiating pointers for your hepatitis C virus based upon your genotype 1 and 3. What you're going to look there, your main modality for younger population will be hepatitis E virus genotype 1, and for your elder population will be hepatitis E virus genotype 3. And animal to animal transmission usually will not be reported, and animal reservoir have been proven in case of hepatitis E virus genotype, and usually will be a sporadic cases in case of in genotype 3, and epidemic cases will be in genotype 1. The severity will be very poor in case of genotype 3, as well as varying severity can happen in a genotype 1. So the usual incubation period, you should remember that around 2 to 9 weeks have been discussed. And the population who are at risk is the sexual members or household members or drug abusers are being risk. And the clinical pointers always, as I discussed with you, the 3 phases you should not forget. And the clinical manifestation, it could be anectic or ectic, as I discussed, and it could be a fulminant hepatic failure, or it could be asymptomatic infection. Just you are going to land up with hepatitis E without much of problem. So always in the initial phase of acute event, the liver enzyme is going to go high, followed by the IgM anti-HEV, it's going to go high, and you can able to identify these RNA levels in stool and liver. And once the patient is going to have a convalescent phase, the patient can go for IgG anti-HEV, which is going to persist for a longer duration of time. And this is how the various modality you can be able to diagnose hepatitis E virus. You can detect by your nucleic acid assay. You can see your proteins based upon your virology structure or one of your components, or you can take your host immune response by an indirect method. So host immune response, as I discussed, either it could be because of IgM, IgG, IgA, various techniques are there to analyze all those things. And once, if you want to diagnose HEV, based upon that, the treatment is always a self-limiting, conservative care. The role of Silliman can be considered, but fulminant hepatitis, you need to follow the stepwise protocol, what has been given in various guidelines and protocols as per AASLD and EASL's position statement, what you mentioned. You need to follow all the guidelines for once a patient is going to land up. Take care of the 10-point measures. Look for evidence of neurology. Look for evidence of septicemia. Look for evidence of hypoglycemia. Look for evidence of coagulopathy. Look for evidence of nutrition. Look for evidence of worsening. All those points to be considered in the armamentarium of managing a patient with a fulminant hepatic failure. So in pregnant women, the transmission rate is very high. You should be cautious. And the vaccine, there are some evidence to try for the vaccine. There is a recombinant truncated form of HCV capsid protein being tried, but these have not been much proven much. And apart from that, if you're going to look into that, the vaccine shows 95% of protective efficacy against hepatitis Z, whereas among those who are going to receive around 3 doses, but we need still more papers to validate this thing, and may be useful for the patient who are going to be a traveler in hyperendemic area and also for pregnant women. But the cost consideration also, everything's to be considered in the background. If you want to manage a patient with hepatitis Z, the vaccination drive has to start in India. And preventive measures, say fecal oral elimination, all those modalities to be taken care into account. And eating uncooked fish, uncooked shellfish, and uncooked fruits and vegetables is better to avoid, and maintain a safe hygienic practice and maintain a safe sewage practice. That's the most important thing. And what is this fulminant hepatitis? This one interesting area. And next to that, ACLF, what is acute and chronic liver failure, which is new upcoming area in the field of hepatology. Why you would like to point out? Because these are all the basic umbrella definition which is going to be there. And there are multiple papers being there to support once a patient is going to land up with acute hepatic failure. So what does this acute hepatic failure? It's umbrella terminology. It could be because of 8 weeks of duration, or it could be because of 4 weeks of duration in the background of a non-existing liver disease in the patient is going to land up with acute infective pathology, followed by your encephalopathy or coagulopathy, or all this point if it is going to get worsened, there is high possibility for you to land up with this acute liver failure. This is how the huge list of cause for this acute liver failure. It could be because of infectious cause or metabolic or drug-induced, drug abuse, always paracetamol to be taken into account. Why? because paracetamol is one common thing which is frequently abusing in pediatric age group. So paracetamol poisoning as per King College criteria, whether it is acetaminophen overdose or not, because all those things to be taken into account, and toxins like aminophthalate can be taken into account for managing a patient with acute liver failure. And fulminant hepatitis can happen either because of A or B or E, but pyrexia usually more frequent in type A, but duration will be prolonged, will be there in B and C. Apart from that, prothrombin, all those pointers, you need to look for that. How are you going to classify this acute liver failure? It's mainly by hyperacute, acute, subacute, or late onset. There are new definitions for ACL have been taken over, but this basic definition, even by the latest textbook of Schlesinger, what they mentioned as hyperacute of less than 7 days, acute of around 8 to 28 days of the onset of presentation, as by O'Grady et al., which has been done a long time ago, and subacute presentation of almost up to around 12 weeks, and late onset from 8 weeks to 24 weeks can be because of any virus. Once a patient is going for acute event from a period of around 8 to 28 days, the patient's prognosis will be slightly poor. You need to be very cautious, and sometimes the patient may deserve an emergency or supra-urgent liver transplant to be considered in this kind of background. And frequently, I would like to state something. In my experience, I have seen many pregnant women suddenly worsening jaundice. Most of the time will be hepatitis A. I have seen my personal experience. Some patients have been managed with this kind of background, with your hepatic protocol and your liver transplant guidelines, sometimes termination of your pregnancy, all those things to be considered if you want to manage a pregnant woman, which is one of the most threatening period for this viral hepatitis to get transmitted. So clinical features, the common scenario like severe jaundice, worsening of your liver enzymes, your prodromal picture, your hepatic encephalopathy, your coagulopathy, your multi-organ dysfunction, your septicemia, and sometimes the evidence of chronic liver disease starting from your head to foot, like spider nevus. All those points just to be taken into account if you want to tackle a patient with fulminant hepatic failure. And leukocytosis can happen sometimes in contrast to leukopenia. Most of the time, leukocytosis in the background of fulminant hepatic failure, there is possibility for you to get a superadded infection, and bilirubin and transaminases always may be worsening, and coagulation derangement will be there. And complications very wide, multi-organ involvement, and it could be ARDS or pulmonary edema, metabolic disturbances, all the electrolyte parameter abnormalities, starting from your acidosis to alkalosis, your respiratory acidosis to alkalosis, your hypoglycemia, hyponatremia, hyperkalemia, hypophosphatemia, hypokalemia, all those electrolyte abnormalities can develop. So once you start your intensive care protocol, it's a separate guideline, a separate thing has to be established if you're going to manage a patient with a fulminant hepatic failure. The systemic manifestations, what have been discussed, it could take a multitude of events. It could predispose to any organ involvement. If you're going to look into the slide, mainly by your immune paralysis and your neutrophilic dysfunction. And once your systemic inflammatory response syndrome, if it is going to take on to that, followed by your sepsis or severe sepsis and septic shock, it's going to establish, followed by there is high possibility for you to land up with multi-organ dysfunction, and finally you're going to land up with death. So this is what the criteria to deserve at this point of juncture, whether the patient deserves liver transplant, is that it's going to happen or not. You need to take all these parameters based upon your acetaminophen induced, see the pH, if it is going to be less acidotic range, if it is going to be less than 7.3, or if your INR, if it is going to be more than 6, or if your creatinine, if it's going to be persistently high, or if the HE grade, if it is not going to improve for more than 3 to 4, as per your West Evans criteria, all those points is to be assessed if you want to point out a patient who had acetaminophen, even after your management with N-acetylcysteine, with the person is going to worsen. All these points is to be taken into account for managing a patient with fulminant hepatic failure. And non-acetaminophen induced ALF, INR, if it is going to be persistently degraded, age-wise less than 10 and more than 40, etiology has to be analyzed, and time interval and INR and bilirubin, everything's to be analyzed. And there are multiple other criteria. Why I would like to state, because Acharya has been given a wonderful statement, see for evidence of neurological worsening. If the patient is going to have cerebral edema, if the bilirubin if it is going to be more than 15, and PT if it is going to be more than 25, and if the patient is having more than 40 years of age. So more than three factors, if it is going to be strongly associated, the patient is going for mortality up to 90%. And MELD scoring, what they have mentioned very well, based upon your bilirubin, INR, and creatinine, you need to calculate your MELD score. And now model modification of your MELD scores are there. MELD sodium status can be taken into account, and deserve the patient criteria, standardize the patient who deserve early liver transplant. Based upon that, you need to initiate the management guidelines. Next to that, the supportive treatments. 24 hours, you need to look for septic screening, blood screening, toxicology screening. These are all the basics, complete liver workup and your vascular workup. Look for evidence of any vascular events, look for evidence of any imaging, and look for evidence of any pleural effusion, look for evidence of any cardiac overload, and do a basic echo, get the opinions of all the consultants, do a neurological assessment, suspecting a metabolic liver disease, do a copper assessment, and suspecting a autoimmune pathology, do ANA, ASMNA, anti-smooth muscle antibody or anti-liver kidney microsomal, depends upon which kind of age group, if you're going to look into that, whether if you're going to tackle a pediatric population or a older population, all those parameters to be analyzed. And based upon that, you need to establish your managing protocol. And complications like cerebral edema, you need to improve that by head and elevation, your hyperventilation, your mannitol protocol, and prevent your hypoxemia, hypercapnia, and sometimes your barbiturate coma can be, and septicemia managing by a higher dose of antibiotic, which is going to cover a gram negative, and followed by renal failure. That shows evidence now plasmapheresis, all those things being taken over, and continuous renal replacement therapy in the background of acute and chronic liver failure is one of the modality you can try. And coagulopathy, you can try fresh frozen plasma, vitamin K, now factor 7. So many other components can be tried based upon your tech assessment, that thromboelastography measurement, all those pointers you need to analyze. Pre and post liver transplant guidelines has to be established if you're going to manage a patient with fulminant hepatic failure who is going to land up with this viral hepatitis. So liver transplant is mainly once the patient is not going to get improved. If the background is the patient is continuously worsening, your multi-organ system is going to get calmed down. You need to segregate the patient at what time you're going to manage, and who is the patient, who is the top priority in Indian population, because getting a liver, it's one of the complex thing, whether the patient is going for a cadaveric or living. So all those points is to be analyzed properly if you want to manage a patient with this fulminant hepatitis. And the contraindication will be once a patient is going for irreversible neurological damage, or uncontrolled septicemia, a severe immunocompromised status, or a coexisting of second malignancy or worsening of malignancy, always you need to consider this kind of background will be a contraindication for your liver transplant in the background of acute liver failure. See, these are all the various data. The better prognosis for acute liver failure in case of hepatitis A virus, in paracetamol poisoning, in ischemic focus. The worst prognosis will be in Budd-Chiari syndrome or hepatitis B or autoimmune. There are so many things, and there are so many list of molecules that have been given, which has not been much of useful in the management once a patient is going to land up with acute liver failure. So giving a branch in amino acids, there are some papers to support all those modalities of treating, but how far it is going to be successful is still a questionable issue in the field of hepatology to manage a patient with a fulminant hepatic failure prior to liver transplant. So hepatitis, why acute hepatitis in the background of B and C, nothing much to discuss, because most of the time we'll be going for chronicity, and 10 to 20% of the patient in B can go for acute event, and most of the time will be an aneuptic focus, and benign cause will be there, relapses will be there. Always you need to see acute hepatitis, whether it is because of acute or it is because of any flare of event in the background of chronic hepatitis. So do the basic virology like HBsAg, HBAg, anti-HBC total, DNA levels, all those parameters, huge list of investigation focus are there to analyze all those things. And due to want of time, I don't want to point all those things, but you should remember acute viral hepatitis B and C mostly will not be happening. Acute hepatitis B can be there, but it is very less for C to go for acute event. But once a patient going for hepatitis B of acute focus, Usually it will be a self-limiting, no role of much of antiviral, except in the background of worsening of coagulopathy or worsening of in the background of if the patient is going for evidence of hepatic failure. Then there is high indication for you to consider even for acute hepatitis B to start on antiviral based upon your clinical parameters, whether you're going to consider NHKV-based regimen or your tenofovir or tenofovir, what are the nucleoside analogs if you're going to use based upon your clinical parameters you need to take into account for a patient who land up with evidence of acute hepatitis B. And treatment is basically symptomatic, no much of antiviral effects are being there. And extrahepatic manifestation is a huge list, as we all know that it could be because of polyarteritis, glomerulonephritis, vasculitis, cryoglobulinemia, Guillain-Barré, genetic cross-cheese, so many other syndromes are being there. And this is all the extrahepatic manifestations of your C virus, your hematological, dermatological, renal. I have seen some patient who presented to us only with evidence of a systemic lupus erythematosus many times who have been landing with hepatitis C virus. And when how far you're going to succeed those kind of patients with your corticosteroid, there might be evidence of worsening of events. So all this, and I've seen some patient who's having coexisting rheumatic pathology in the background of methotrexate therapy, in the background of hepatitis B and C. How are you going to manage those scenarios? These are all separate areas that we can discuss in a separate forum. But why I would like to point out all those things, there are huge list of clinical pictures there if you want to diagnose this entire spectrum of hepatitis in a single forum. Then hepatitis D is always a super added virus in the background of your hepatitis B. So it could be, it's mainly a satellite virus which is going to replicate in the background of hepatitis B, and the short incubation period of around 2 to 12 weeks. And the primary modalities like what is going to happen for your B virus, risk factors similar to your B virus, like any sexual abuse, drug abuse, or any syringe, all those things. And apart from that, children may be affected by this hepatitis D virus. And the clinical picture, remember 2 pointers, whether the patient is going to have acute hepatitis B virus, the acute hepatitis D virus, co-infection. In that scenario, what is going to happen? There is evidence for your delta as well as your hepatitis B to go together at the same time. Or there is any super infection in which a delta infection occurs in a person already who is going to harbor a hepatitis B virus. So it could be because of acute, or it could be because of coexisting, or it could be because of superadded, or it could be because of chronic hepatitis G virus infection. That's a separate entity. So you need to look for your delta antigen in your investigation parameters. And usually the antibody appears after 2 to 3 weeks after the infection, and it soon may replace by IgG. So co-infection, how are you going to diagnose? So you need to see your high titer of your anti-HPC, IgM for your hepatitis B, as well as your IgM anti-HDV if it is going to be there. But in case of super infection, what is going to happen? It's marked by the early presence of serum IgM and anti-HDV at the same time as early IgG anti-HDV, and both antibodies may persist. So this is how your co-infection and super infection you're going to diagnose. And how are you going to prevent? Nothing much. Vaccinate the patient for hepatitis B, and look for, once a patient is going for worsening of events in the background of the background of chronic hepatitis B, always look for evidence of HDV, whether it's going to be coexisting or is there or not. And next to that, the treatment, nothing much, no much of treatment. And high dose of interferon, some regimens are being tried, and most of the time the treatment is unresponsible and no responsibility, and most of them will be unsatisfactory. And these are all the other few areas of virus what we are going to look into. This hepatitis G virus almost will be taking a form of family of Flaviviridae, and similar modality of transmission like even hemodialysis, IV drug abuse, you being there. And look for extra GI sources, non-hepatotrophic pathology. Look for evidence of yellow fever by your group B arboviral infection, and common period of incubation will be 3 to 6 days, and clinical picture will be same most of the time. Look for evidence of any vascular leak like hemorrhages, and jaundice and albuminuria always can supervene. This is how your basic picture of your yellow fever can land up with this kind of presentation. And next to that, diagnosing is demonstrating your IgM antibodies in your yellow fever. And these are all the basic things, nothing much to discuss, no much of specific treatment. That's why I'm rushing up into the slides. And Epstein-Barr virus, look for evidence of nodal involvement, look for evidence of pharyngitis. Sometimes those kind of presentation may be absent. And always Epstein-Barr virus, you need to rule out a coexisting immunocompromised status. Most of the time will be asymptomatic and no much of treatment. It could be having a coexisting lymphoproliferative disorder also. All these things to look into that if you're going to manage a patient with acute viral hepatitis. And diagnosing is mainly by your clinical picture and look for your IgM antibodies against your Epstein-Barr viral antigens, and followed by this is a basic picture how you're going to differentiate and massive hepatomegaly, splenomegaly, clinical picture, and onset of presentation based upon your clinical pointers, your EBV or your viral hepatic focus. This is how once you're going for a liver biopsy, will be a predominantly diffuse infiltration for the infectious mononucleases by ABV, or it could be because of your predominantly zonal necrosis in case of viral hepatitis. This is all the basic picture, nothing much to discuss in this area. But cytomegalovirus is one complex, one more entity where we having a granulomatous hepatitis will be having, and usually the leakage will be lasting even up to 3 months for this kind of patients. And pyrexia, jaundice, and other things can supervene. And why I should like to point out this cytomegalovirus, it can go for AIDS-related cholangiopathy. It can predispose to, followed by your cholangitis, papillary stenosis, and your sclerosing cholangitis. All those parameters can get worsened out by your cytomegalovirus if it is going to supervene in your finding. And isolation of the virus is the most important, but it's very complex phenomena to do that. And herpes simplex, nothing much. So regarding it can happen in your in pediatric age group to adult population. Disseminated herpes simplex is very rare, but if the patient is going to have immunocompromised or HIV or ulcerative colitis, if the patient is going for long-standing medications, those kind of patients can have a super added herpes simplex hepatitis also. And fulminant hepatic failure can develop in the background, but the management protocol remains the same. And these are all the exotic viruses. And one more virus like Marburg, Ebola, Lassa. There are so many exotic viruses in which you can able to die, you can able to present, but not much common scenario, at least when we are facing in outpatient. Why I have taken those slides also, you should remember there are a huge list of epidotrophic and non-epidotrophic viruses are there to manage a patient. And prior to concluding, what I would like to point you all, you need to clinically analyze the patient well. You need to manage a patient, analyze with the basic investigations, look for the clinical spectrum, how you're going to tackle a patient with viral hepatitis, look for the various prodromes, do a head-to-foot clinical examination. Without your clinical pointers, rule out any other coexisting superadded pathology. I have seen most of the patients in India will be taking a over-the-counter medication. Many local persons are being giving unnecessary molecules, over-the-counter drugs are being used by many local practitioners. Are being so there may be evidence of them to use this kind of molecule, followed by your drug-induced liver injury to supervene. All those things to be analyzed. There are many centers are there to unnecessarily over-treat this kind of viral hepatitis. So why I would like to point, no management absolutely indicated. Just wait, watch, look for the clinical scenario, see whether the patient is responding or not, and treat the complications, and discern the patient, whether the patient is fitting for liver transplant or not, and establish the guidelines. Once the patient lands up with hepatic failure, follow the 10-step protocol regimen for your liver failure, and tackle this viral hepatitis successfully to overcome all the complications. That's what the main area before winding up in this World Hepatitis Day for me to discuss with you all. And thanking you all for patient listening. And I'm happy to take up your questions if anything is there to take on.
So thank you very much. Really very, very useful and excellent lecture. I'm sure all the participants have really enjoyed listening to you. So there are a few questions. Can I take them, sir, one by one? Yeah. Right. Actually, quite a lot of questions are there. The first question is, where do we use UDCA in this?
No much of beneficial role for UDCA in any acute viral hepatitis because most of the time will be a symptomatic phenomena. But that shows some evidence of anti-inflammatory, anti-fibrotic effect for your UDCA. And once a patient is going to land up with a cholestatic pathology, for example, in the background of acute hepatitis A, there might be evidence of a choleratic effect of this UDCA. So can be considered in those kind of patients with high bilirubin, high ALP levels, alkaline phosphatidate is going to be high elevation. There might be showing some indication for that kind of background in the management of your around 300 milligram GDS or 450 milligrams BD. You can consider for a duration of around 4 to 8 weeks in the management of your acute viral hepatitis.
So the next question is, what is the mortality rate of hepatitis E in pregnancy?
Uh, It's a good question actually. The mortality rate normally for hepatitis E is very less, will be around 1 to 2% usually. But once a person is going for pregnant women, the mortality may climb up to 25% also because there are so many things to look into that. And once a patient is going for pregnant women, the 4 to 25% mortality can happen, and most of the time the patient can end up with fulminant hepatic failure. That's why we need to strongly address if you're going to tackle a woman, it's more difficult in real life scenario also in tackling a viral hepatitis scenario.
So this question is from Dr. PM Jain. Can paracetamol be used as an antipyretic in viral hepatitis?
No role for antipyretics in viral hepatitis. So just wait, watch, and monitor. But one dose of paracetamol doesn't going to harm your scenario. But sometimes if the patient is going to have coexisting other pathology, for example, in the background of acute viral hepatitis, if the patient is going to have a renal injury, in the background of acute viral hepatitis, if the patient is going to have a chronic liver disease, in the background of acute viral hepatitis, if the patient is going to have a thyroid illness, there might be drug elimination will be indirectly affected. At that point of juncture, what is going to happen? Your drug toxicity, even at minimal dose, can supervene, and there is high possibility for you to land up with any complication. Unless and otherwise, if the patient doesn't have any major complications with your pyrexia, wait, watch, tepid sponge, monitor, analyze, and expect the clinical outcome.
So why severe liver damage happens because of hepatitis C in pregnancy? Hepatitis E. Hepatitis E, sorry.
That's what I've been discussed with you all. Now, see, this hepatitis E virus, what is going to happen? It may cause mortality up to 4 to 25% in case of pregnant women. So why I would like to say, because it is going to alter your cellular immune response. So in what way it is going to alter your cellular immune response? Mainly by targeting your nuclear factor pathway. And also it is going to target your TLP1 and TLP2 cells pathway. And also it may have an effect on your estrogen as well as in your progesterone-based receptors. It may down-regulate your receptors in the female tract. There is high possibility for this kind of patients for them to land up with this kind. But these are all the hypothetical events being coined in various papers, but we need more and more data, still more a questionable issue. Why pregnant women is being more targeted in the management of, in the pathophysiology of acute hepatitis E.
Okay, let's. So there is another question. Whether extrahepatic manifestations can occur in acute hepatitis B?
It's a good question, actually. Usually in chronic hepatitis, the extrahepatic manifestations are reporting, but there might be evidence even acute hepatitis can land up with extrahepatic manifestations also. Like your polyarthritis nodes and like your cryoglobulinemia. For example, if you're going to look into your cryoglobulins, there may be cryoglobulins type 1, 2, and 3. Type 3 will be having predominant effect in your liver and other cells. So you can have a worsening of events, and you may land up with polyarthritis nodes and your dermatological manifestation of vasculitis. All those complications can report as an acute event, but the possibility when compared to the chronic presentation in acute manifestation, the patient, once the patient is going for severe worsening, the acute GA, extra GA manifestation is going to be there, but not in the initial phase. but not more common in the initial phase.
Sir, can you tell us about your opinion about transfusion transmitted viruses, TTV?
Transfusion transmitted virus is a separate entity to be taken out of the discussion. It's something also called as Charula based virus. Why I would like to talk into that, it's mainly as the concept of transfusions, there is possibility for this kind of events to worsen and mild hepatitis and mild jaundice to supervene, but it's usually will be recovering on its own. Nothing much more complexity to discuss, and it's usually a DNA based virus. It's not very complex phenomena to understand.
I think there's a follow-up question to pregnancy thing. How to manage acute viral hepatitis during pregnancy?
I think some magician has questioned that.
Yes.
Acute viral hepatitis during pregnancy is really a tough scenario, and you need to see, as I discussed with you, whether the patient is going for evidence of hepatic failure is there or not. Always, pregnant women do not terminate the pregnancy for just a simple viral hepatitis. See the patient, assess the patient clinical status, as I discussed with all the pointers what is there, and try to treat the patient with the conservative measures what is best possible in your limit, in your setup. And unnecessary interventions, not much of recommendations in the background of pregnancy. And overdosing medications, over the counter prescriptions is not much of recommendation. The question is, when you going to terminate this kind of patients, whether the patient deserve liver transplant, or during the period of liver transplant or post transplant, there might be some evidence in the background of fulminant hepatitis. Some background of termination of pregnancy can be tried, but usually you need to maintain the pregnancy. No need much for termination, and sometimes your oxytocin induction. There are so many protocols are there for a gynec session that we can discuss in a separate area. But why I would like to point, the premature rupture of membranes, if it is not going to set in the early phase, we can always wait, watch, monitor, treat conservatively in the background of a pregnant woman who is going to land up with acute event of hepatitis.
So this question is on post-exposure prophylaxis. What is a post-exposure prophylaxis for Hep A? Can we consider immunoglobulins?
So post-exposure prophylaxis, definitely you can consider immunoglobulins, no doubt about that. We can give at a day's road, at a dose of around 0.02 ml per kg, we can try based upon your various areas of exposure. And apart from that, vaccination also you can induce to this kind of patients if you're not going to vaccinate it prior. And pediatric age group also you can recommend post-exposure prophylaxis safely, even if the child is going to be less than 1 year. But vaccination protocol is to strongly address once the patient is going to cross more than 1 year.
This question is from Dr. Subodh. Sir is asking, can herbal medicine or homeopathy or Ayurvedic medicine itself can cause acute liver failure? If yes, what will be the picture in such cases?
These are all the things which may predispose to a drug-induced liver injury. The herbal products which will be predisposing to drug-induced liver injury, it's such a vast entity. Once a patient is going to land up with your drug-induced liver injury, it's always a diagnosis of exclusion. See, we know that the patient is illiterate population. Over-the-counter medications are being used. Just like that, they are being taken some leave. They are taking some extracts, all those products. And I have seen many patients in Chennai who have been presenting to me with evidence of worsening of hepatitis following intake of some leaf or some extract. Why I would like to point out all these things, even in that kind of background, you need to rule out all the events. See, in medicine, one thing we should not forget, tackling the patient is not that easy. And moreover, getting into the diagnosis by just looking into the patient, it's not that simple. Always you need to think an overall picture. You need to analyze what are all the various complete differential diagnosis can be considered in this patient, and what is the top priority for your diagnosis, followed by you need to analyze. And once it's a drug-induced liver injury based upon your herbal medications, then it is mainly by your diagnosis of exclusion. You need to exclude all the factors. Then only a delay can be considered. So there are scoring system for Delhi, nothing but RUCAM scoring. It's a resolve ECLAF scoring system based upon your AST, ALT, elevation, your R ratio, your confounding factor. There are so many separate areas for that to be discussed if you want to manage a patient with drug-induced liver injury.
So there's another question follow-up to post-exposure prophylaxis. They have not name has not been displayed. When a patient is supposed to take post-exposure prophylaxis, I mean, after how many days or months of exposure, 10 HBIG dose can be taken?
So, for a patient with suppose hepatitis A virus, if you're going to take immunoglobulin, ideally within a period of 2 weeks of time, you need to consider, but not more than 4 weeks of time. It's been replicated. So, the main area within a period of 2 weeks of time, you need to consider the post-exposure prophylaxis as early as possible.
Sir, Dr. Krishna Reddy, this question, NAFLD treatment. Doctor wants to know NAFLD treatment.
NAFLD, the common thing, nothing but look for the metabolic syndrome. Once a patient is going to have evidence of metabolic syndrome in the form of hypertension, hypertriglyceridemia, your obesity, your insulin resistance, type 2 diabetes, all these pointers to be addressed properly. Take care of your thyroid, control all these things, and start by your diet modification, lifestyle modification, cut down your high fat diet and lifestyle modification in the form of exercise at least around 5 to 6 hours in a week. That's the most common in the form of aerobic exercise. Some evidence of vitamin E, some evidence of multiple drugs are there in the armamentarium to manage a patient with non-alcoholic fatty liver disease. But non-alcoholic fatty liver disease also sometimes can mimic your presentation of your acute hepatitis, but it's usually you need to consider other parameters strongly if you want to address this phenomenon.
So what is the role of silymarin in viral hepatitis?
I think I have discussed with you all. It's mainly a milk thistle extract. So if you're going to look into that, the role of silymarin is mainly by anti-inflammatory, anti-fibrotic, anti-proliferative, anti-apoptotic effect. There might be evidence if you're going to use for a period of at least 2 weeks to minimum duration of at least 2 weeks at a rate of around 140 milligrams twice daily. There are some papers being given in that, but silymarin usage can be considered, but it's not only the ideal drug to be used, but you need to consider other molecules in the background of worsening of events. Along with that, we can also add silymarin in the armamentarium of your management protocol.
Sir, is there a role of silymarin in hepatitis C infections?
This is a good question. I think some gastroenterologists have posted this. And see, there is role of silymarin in hepatitis C virus. If you're going to look into that ASLD protocol, what have been given in 2019 in a statement, what have been mentioned, intravenous silymarin being tried in your hepatitis C viral extra. There are some papers to quote that, and along with your molecules of virology and along with your interferon, other things, if you're going to use that, there might be evidence of down regulation of your HCV RNA level, but we need still more papers to validate this concept.
Okay. So there are a few more questions. Can I take them, sir? A few more.
No
actually, yeah. Some of them actually related to vaccine. Before I take all the questions together on vaccine, there are a couple of questions. One is again on pregnancy. If mother is HPV positive, then what is the vaccination protocol? And should treatment be started in the last trimester? And if yes, then which antiviral? Dr. Himali Soni.
See, once a patient is having, that's what I've been discussed with you. If you're going to start, tenofovir is ideal antiviral for a patient with pregnant women. But if you're going to consider that, if the virological parameter DNA, if it is going to be more than 20,000, it's definitely a high pointer for you to start. But mostly asymptomatic, less than 2,000, no much of indication, just wait, watch, monitor this kind of patients for managing a patient with, hepatitis B in the background of chronicity. For acute hepatitis B, no need to do anything, just wait, watch, and monitor.
Yeah, there's a comment, I think, Dr. Ujjwal Kumar Sen Gupta, IMU Bengal State Branch President. He's telling huge mortality rate in Hep B and C, and access to Hep B vaccine is not even 50%. So therefore, awareness is the form of observing World Hepatitis A is very much necessary.
Yes, what you said is absolutely true, doctor. We need to follow that. In India, even the COVID viral vaccination has not been well much updated as of now, as you are well know that. So, how far the people are going to be educated, how far the knowledge is going to be taken over to the basic population. In that way, we can able to pretend. If you're going to stick on only to COVID virus, another scenario, you're going to miss up most of the other viruses which is going to happen in your life, which may predispose to worsening of your events, which may predispose to coagulopathy, which may predispose to chronic liver disease, which may predispose to hepatocellular cancer. Always vaccination drive has to be strongly addressed, and check your anti-HBs levels once your vaccination drive has been done at a regular interval to see whether the patient deserves a vaccine booster is needed or not.
So what is the cutoff of HPV DNA to start antivirals?
Based upon there's no single cutoff for that. Based upon your clinical picture in the background of chronic FB, for acute FB, as I discussed, once a patient is going for fulminant, as if the patient is going for worsening of INR, there is possibility for you to tackle with acute hepatitis B with antivirals. But in the background of your HBeAg positive or HBeAg negative, if it is going to be HBeAg positive, no much of indication, just wait, watch, and monitor. But in the background of HBeAg negative, if your DNA, if your HT levels is going to be, if your fibrotic index is going to get proliferate, increase in the fibrotic range, if it's more than 8 to 9, there is high possibility for you to go for early fibrosis, cirrhosis. At that point of juncture, if it is DNA, if it is going to be around 2000 also, that is pointer for you to consider the patient either with tenofovir or entrecavir based therapy for your hepatitis B virus to tackle. Well,
this question is from Dr. Mala. Madam is asking whether mefenamic acid can be used.
Mefenamic acid can be used only for dysmenorrhea and not for this kind of scenarios.
There are a couple of questions on vaccination. Dr. Pinky Chakravarti, scope of adult hepatitis A vaccination in India.
Adult hepatitis A vaccination in India, because of the one thing is the cost issue. The cost is almost around 1,200 to 1,300. That's one of the different things. One complex entirety for this hepatitis A virus vaccine drive, which is not happening much. And next to that, hepatitis B is slightly a cheaper one, which is also by a national viral hepatology program, which is going to be initiated for hepatitis B virus. But how for this hepatitis A, since there is no much of mortality being considered, so the vaccination drive is still not much of establishment. And but in case of once a patient is going to land with the coexisting infections like B, we need to vaccinate our high endemic areas vaccination, or in the patient in the background of household context of hepatitis A, all those pointers for them to be addressed if you want to manage a patient with hepatitis A virus vaccination. But the questionable issue, the cost, and in India, whether it is feasible to all, it's still not possible. Because even for hepatitis B, if you're going to look into this WHO recent statement, what we mentioned, the global vaccinated population, even for HB, it's not even more than 50% as of now, which is going to happen.
This question again from Dr. Soni. When to give yellow fever vaccine and how many doses?
I think I'm not very sure about the dose regimen, but it's ideally a single dose or 3-dose regimen. I will look into that. But yellow fever vaccination is mainly recommended for those who are going to travel to a hyper-endemic area and you're going for any international travel for those patients. But there are 3 drives are there. But what is the dose regimen? I think it's 3. I will look into that. I will let you know the answers for that.
Yeah, usually single dose is the primary dose. Anyway, let's move on. So the next question is, what is axillary liver transplantation? From Dr. Kishore. Yeah.
See, there are 2 modalities for you to consider this liver transplant. One is by a living donor, cadaveric liver transplant. Among them, is the same graft what you're going to use. The other graft what you're going to use is based upon your, that is what an auxiliary liver transplant. What is the other terminal is going to, whether the patient is going for a split liver transplant regimen, 2 types of separate donors are going to be established. All those things to be addressed if you want to consider this axillary liver transplant.
So the one last question is, which is on how will you differentiate acute Hep B hepatitis D virus co-infection from acute hepatitis B and HTV superinfection?
See, it's a nice question. There is a separate differentiating point for acute HBV, HDV co-infection and super infection and chronic HDV infection. In all those patients, the HBsAg will be positive. But the main thing, IgM anti-HBC, if you're going to look into that, will be predominantly positive in your acute phase. That's a great thing you should remember. What is going to happen here? IgM anti-HDV. So it might be weakly positive in case of your acute hepatitis D, but it might be positive in case of your superadded infection. So always you should remember that weakly positive and positivity. And in case of chronic infection also, it will be positive. But HDV RNA for this pointers to differentiate is for acute event might be positive early, but and usually will be a transient phase. But in case of acute HDV super infection, will be having a persistent phase of this event, and in case of chronicity, will be usually long lasting. So there are so many pointers for taking into differentiation for this acute co-infection, HDV super infection, and chronic HDV.
Can silymarin be used in chronic active hepatitis?
Silymarin can be tried in chronic active hepatitis, but not only the single drug, as I've already been discussed, the same beneficial role. But there are some papers what have been quoted. You can also try for chronic hepatitis, for alcoholic hepatitis, for hepatocellular cancers. And if you're going to look into this various guidelines, what they mentioned, so many uses of for acute viral hepatitis by your T cell receptor modulation, all those things can be tried for with your silymarin, but it's not only the single molecule to be considered. You need to always add on based upon your clinical presentation.
So that was the last question, and there are a few comments which I will read out, and it is also my opinion, also same way. Excellent and useful talk by Dr. Arun. This is from Dr. Jeevan Kumar and Dr. Pinaki Chakravarti. Exhaustive and nice presentation. I think I agree with all of them. It was really a very, very comprehensive presentation and extremely good Q&A session, which you clarified a lot of doubts which people have. Thank you so much for joining in and making it very, very useful evening and very, really very enriching experience for all the people who are joining. And also I take this opportunity to thank all the participants who made it so very interesting and asking such wonderful questions. So it was very, very useful and definitely it will help you in your routine clinical practice. So thank you very much, Dr. Arun. Thank you all the participants. Now I hand it over to Ms. Savitri to do the official vote of thanks. Over to you, ma'am.
Thank you. Thank you, Doctor. And indeed, it was an excellent presentation. Really very important clinical pearls to all the audience. It's my privilege to thank all the audience who are viewing not only in Zoom but also in the YouTube. It is being streamed. And thank you, Madam Manjula, for coordinating it so smoothly. And as usual, I'm thankful for your support.
Thank you.
Thank you one and all, and have a great evening. Thank you.
Thank you all. Good evening. Bye.
Thank you.